Welcome to part 1 of our 15-part masterclass series. If you're a certified medical coder, a biller, an auditor, or a healthcare provider, you already know that the revenue cycle basically lives and dies by accuracy. In this explainer, we're going to build a robust, highly practical foundation for evaluation and management coding. EM coding is the absolute backbone of outpatient and office billing, and mastering it, well, it's completely non-negotiable for compliance and financial health. I am thrilled to guide you through this, so let's jump right in. Here's a quick look at our agenda for today's session. We've got 1. The basics of EM. 2. Why EM levels matter. 3. Patient A versus patient B. 4. MDM versus provider time. And 5. Wrap-up and next steps.
Section 1. The basics of EM. Let's start right at the absolute foundation of our practice. So, what is evaluation and management coding? It's the process of assigning appropriate codes to describe patient encounters with healthcare providers for billing and reimbursement, reflecting the complexity and level of service provided. Basically, EM coding is the critical translation of clinical work into standardized language. It takes into account the complexity of the patient's condition, the history taking, the physical exam, the medical decision-making, and the time spent. Essentially, it's how we capture the intellectual work of the provider and put it into an actionable, billable framework.
Section 2. Why EM levels matter. Understanding the definition is one thing, but we really need to grasp the tangible impact this has on everyday operations.
Why do we actually care about assigning an exact EMM level, like a 99202 or 99203? Well, first and foremost, it guarantees appropriate reimbursement for the time and complexity involved. Harder work should mean a higher level, which naturally equals a higher payment. But it's not just about the money. Assigning the correct level is absolutely crucial for audit readiness. Your documentation has to firmly justify the services billed. It also ensures fairness and strict compliance. Plus, it gives practice managers a really reliable metric for tracking provider workload and quality.
Section 3. Patient A versus Patient B. Let's look at a real-world scenario to see exactly how this plays out.
Imagine Dr. Metha at an urgent care facility down in Texas. He sees 2 patients back-to-back, and I want you to notice the stark contrast in the clinical workload here. Patient A comes in for a mild hypertension follow-up. Dr. Metha reviews the BP log, makes absolutely no medication adjustments, and the whole thing takes about 10 minutes. Then, patient B walks in with new onset chest pain. Now Dr. Metha is doing a full history and physical, ordering an ECG and labs, and wrestling with a complex differential diagnosis. That visit takes a full 30 minutes. Night and day, right?
And here is how that clinical difference translates directly to the coding level and reimbursement. For patient A, that simple 10-minute check gets a low-level code, a 99212, reimbursing around $120. But for patient B, that intense 30-minute chest pain evaluation jumps to a moderate to high-level code, a 99214, which pays $240. The work was undeniably harder, the risk was much higher, and the coding accurately reflects that reality.
Section 4. MDM versus provider time. So, how exactly do coders and providers decide which level to assign to these varying encounters?
Today, you are basically required to choose an ENN visit level based on one of 2 distinct pathways. The first is medical decision-making, or MDM. This is based entirely on the problems addressed, the data reviewed, and the risk of complications. The second pathway is total provider time. This is based literally on the exact total time spent on the day of the visit by the physician or other qualified healthcare professional. That includes prep, the exam, counseling, ordering tests, and charting.
Now, if you take absolutely nothing else away from this explainer, memorize this golden rule. Use whichever method allows the highest appropriate reimbursement. Seriously, you have the total flexibility to choose either MDM or time to reflect the work done and secure the optimal, compliant payment. It's not some sneaky loophole. It's the fundamental design of the current guidelines. You run the visit through both filters, and you just select the one that supports the higher level, assuming the documentation backs it up.
But a quick warning here. Time-based coding comes with very strict rules. The documented time must be a single specific time, like exactly 20 minutes. You absolutely cannot use a range like 15 to 30 minutes. If the provider notes a range or, forgets to document the time entirely, you lose the ability to use time. In those cases, you must default to MDM. When it comes to the chart, accuracy is just everything.
Section 5. Wrap-up and next steps. We've covered a ton of ground setting up this foundation, so let's summarize it.
Here is a quick EM summary cheat sheet. First, EM reflects service complexity for accurate billing. Second, those levels are based on the setting,
the patient type, and the clinical complexity. Third, you level the visit via MDM, looking at problems, data, and risk, or by total time. Fourth, you always choose the method offering the highest appropriate payment. And lastly, time must be exact. Otherwise, you default right back to MDM.
Mastering this introductory logic really is what separates good coders from great ones. So ask yourself, is your practice leaving legitimate revenue on the table simply because providers aren't documenting the true complexity of their medical decision-making? It happens all the time. In Part 2 of our masterclass, we are going to do a deep dive into medical decision-making and really master those new MDM tables. You won't want to miss it. Decode Healthcare with Harshal.